Hello, my name is Hannah Walker and I am here with Chris Cloak-Brown and Roger Houston from Owlicity, who are highly experienced in providing insurance for functional medical practitioners. In his book, Outlive, Dr. Peter Attia describes a move from the current Medicine 2.0 to a Medicine 3.0 modality. So first of all, Roger, what is Medicine 3.0 and how does it change the required approach from risk management and indemnity?
So I think perhaps if you think of Medicine 3.0, so education has the 3 R's, Medicine 3.0 has the 3 P's, so it's personal, it's preventative and it's participatory. So if you think of it maybe in a slightly different context, most people who run a car carry out some form of maintenance, whether it's via a garage or you do something yourself. What you don't do is you just sit around and wait for a breakdown. And Medicine 3.0 is really the healthcare equivalent of that.
Okay. And I know you have a lot of experience with helping practitioners correspond with the GMC. So what would you say are the biggest risks?
So I suppose there are 2. The immediate personal professional one is definition. What it is a patient can and cannot expect, and therefore that rolls out the definition of the services that you're offering. And the other thing I would say is it's communication with the patient's GP. You know, you can't over communicate. Of all the cases I've dealt with, between 2/3 and 3/4 of them were triggered by a complaint to the GMC by the patient's general practitioner.
Okay. And let's say we're talking nutritionists or people who provide diet and exercise advice. What advice would you have for them for whether this is classed as a medical treatment?
So it's interesting in that functional medicine brings together different components. So when you look within functional medicine, there's an awful lot of nutrition, there's an awful lot of biochemistry. These are things that are not taught in detail at medical school. So those are all very important components.
Yeah.
However, to provide treatment of disease, you need to be a doctor and therefore GMC registered. So it's difficult as a nutritionist in that it's fine to say, I give nutrition advice, dietary advice. You could say I give dietary advice to lose weight. It progresses. As you start to say I give dietary advice for heart disease, then you are into the realms of treatment of heart disease, and strictly speaking you should be a doctor and GMC registered. So what we're seeing is it makes sense for a doctor to team up with nutritionists, possibly even biochemists. You see all these sorts of people in that kind of space and all interested. But Roger, I think you would agree that in that context, because it's still a medical treatment context, the risk stops with the doctor. They are clinically responsible.
Yeah, it's very clear from the cases I've been involved in is that the GMC look to be as inclusive by way of the regulation of doctors as they can be. The torch they carry is for patient safety.
Yes.
So you can understand why they would do that. I think in terms of if you take the guidance, if you're prescribing as a physician, even recommendation as to exercise falls within the GMC definition of prescribing. So it doesn't take much for a physician to step over into GMC land, as it were.
Yeah.
So the net's both broad, but the mesh is also fine depending on precisely how you interact with any particular patient.
This is quite an interesting, as you're saying, we're moving from Medicine 2.0 to Medicine 3.0, so the delivery of services is moving on. And this is a bit of another classic example where the delivery of services is moving on, but the regulation is still regulating the services as was.
I see.
So it is a tricky area.
Yeah.
It's one of those areas where a physician just saying do some exercise is prescribing under the GMC rules, but a physiotherapist who tells you to go and do exercise isn't GMC registered, so can't be prescribing. So
It's tricky.
yeah.
It's
Yeah.
really tricky.
So you have, as a doctor, I think you have to be quite wary about what you're doing in this space.
Yeah.
Because you are just held to a higher standard because you're deemed to be better qualified and it's deemed to be your profession.
Yeah. But if a nutritionist is not a doctor, then what do they need to be wary of? What are those key things they need to be wary of when providing their service?
So I think it comes down to several things. Demarcation again, I'm afraid, the dreaded D word, which is the happy hunting ground for lawyers.
Yeah.
So without mixing too many medical metaphors, if the treatment bleeds, if the advice bleeds over from the nutritionist into treatment, that's an issue because they are not GMC registered. Equally, the indemnity in respect of covering the work that they do has to be broad enough to cover what it is they actually do. So again, you know, particularly for the GMC registered doctor.
It's really interesting in these setups, and we've debated that. So if you're working with a doctor as a nutritionist and your work is engaged then in the diagnosis and treatment of disease, you actually need to ask your insurer if I'm insured for the diagnosis and treatment of disease, because that is very different to just providing nutritional advice. I mean, Age Concern have nutritional advisors who answer, you know, phone calls from lovely old ladies about and tell them to eat, you know, cans of carrots and things like that, which is great and very valuable. But that is very different from telling people what to eat to avoid or to improve, well, certainly cancer being highly emotive.
Yeah.
So to improve their chances of surviving cancer, that's a very different position.
Yes. So if a nutritionist and a doctor were to team up, create a practice, then how is that clinical responsibility divided between them?
So again, it's a matter of defining the patient journey and internal demarcation, this time between the function of the in-house nutritionist and the in-house physician doctor.
Yeah.
So again, that's not beyond the wit of man, and we've given advice to a number of clients, both individually and as teams, around where those lines may fall, because it has implications on indemnity, but it also logically drops out to how you apportion costs internally and that kind of thing.
Okay.
So it's about understanding the patient journey and about definition.
Okay. And we know that functional medicine, it's personalised in nature, isn't it? So how does a practitioner assess whether the providing of the treatment outweighs, you know, that risk to obtaining informed consent? That's a tricky balance.
Yeah, so I think as we say, as Chris has mentioned, you know, Medicine 3.0 is an evolution. It represents personalised medicine. It represents much more of a life journey with your medical attendant, if you like, rather than going in the event of a breakdown, to overwork the car analogy. So in terms of consent, I think, as we were saying, it's a hybrid between the work of a general practitioner and the work of a consultant.
Yeah.
So typically, as we all know, when we go along and visit our GP, we won't sign a consent for that. Consent is inferred. If, however, there's a particular procedure that the physician thinks we ought to undergo as a patient, then there will be the usual consent, informed consent, risks or benefits over risk, as is normal. So I think increasingly we'll evolve to a hybrid situation where discrete consent will be relevant to discrete episodes of treatment, but there will be this general acceptance, inferred acceptance, that when we turn up to see our functional medicine practitioner for our biannual MOT or fitness, whatever it is, to attend that consultant's inferred.
Okay. And let's talk the Care Quality Commission. Roger, I'm going to come to you for this one. What are the benefits for being registered to the Care Quality Commission, and what would you say are the potential constraints if one was not to be?
So the CQC is an interesting animal in the sense that if you look at the regulation and you're a functional medicine practitioner, particularly if you're wanting to start an FM business, broad areas of what you would hope to achieve are excluded specifically by the regulation. However, the twist is that medical treatment of whatever type is within the ambit of the regulations. So you've got this dipping in, dipping out if you're not careful, depending on what it is you're doing.
Okay.
So the constraints are the process itself, and I think I'm right in saying, Chris, current lead time is about 10 months for new entry businesses
Right.
to make an application and to be processed and hopefully succeed. There's the costs associated with it. So those are perhaps as well as the constraints of are you in or are you out if you're an FM practitioner. The benefits are undoubtedly public confidence.
Yes.
And the actual codifying and consistent raising of standards across the profession, which no reasonable person would have a problem with, and we most certainly
I think one of the big benefits would be, especially where you're looking at these more avant-garde treatments, is people might be concerned, but when you put the CQC stamp on it, that will make them comfortable that it's not out there and crazy, and they can be comfortable that they're getting an effective treatment.
Okay, but what would you say a FM practitioner needs to be wary of then when registering and complying with the CQC?
So again, it's being absolutely crystal clear and well defined in what you're offering, and therefore you can decide whether you're in or out in terms of whether the prescribed exemptions apply or not.
Yeah.
You know, the lead time's an issue in terms of just the commercial realities of trying to launch into that area.
Yeah.
Other than that, it will be the regular monitoring that goes on during the course of your registration life with them.
I think a big takeaway for us for what we've seen is CQC is definitely not for the faint-hearted. And so it's quite easy to think of functional medicine as, a little bit strange and not as formal as regular medicine. In fact, from some of the best functional medicine practitioners that we've seen, their prescribing policy is absolutely immaculate, including all the off-label prescribing and how they approach that. It's in enormous detail with absolute rationale for what they do, how they do it, why they do it. It's as good as anything sort of mainstream that we've ever seen. So it's different, but that doesn't mean it's any less rigorous, and the CQC process has a lot of rigour to it. So it's difficult, but the goal is that you get that stamp of approval.
Yeah, for sure. And let's say then your business is registered, it's compliant, it's open for business. What would you say practitioners need to be wary of when it comes to the marketing of their services? And is there any information that needs to be readily available for clients?
Yeah, so I think that comes down to, again, definition, so that you can be absolutely clear in your marketing material of what can and can not be expected. The CQC, your registration, again, has to be acknowledged, a bit like your employer's liability certificate. There has to be the certificate in reception. I think anecdotally, having been on this journey for a good number of years, it's interesting how functional medicine is almost an evolution of a cottage industry. So there are a number of GPs around who are dissatisfied with medicine 2.0 because of its rigour, because of popping pills into people, and you're balancing adverse side effects in many respects. The number of people that have said to me that they start these businesses by trying to treat almost friends and family, not quite friends and family. So anecdotally, I would say that your FM patient is not your friend. The road to the GMC is littered with failed friendships that have been sacrificed on the altar of FM medicine going wrong. So in terms of the rigour of it, it's as rigorous, and the patient-practitioner relationship has to be as formal. Just because you can have coffee and you're sitting in easy chairs round doesn't mean that the medicine is any way less serious.
I think it's interesting what you say about cottage industry, and that is when you're starting a functional medicine practice with this long lead time into CQC, that is a real barrier to entry, and if you want to be treating disease in CQC, you have to get there. You can, in the meantime, provide a lesser service, so a service that's all around advice on diet, nutrition, health, and so on, but so long as you keep that out of your CQC requirements. So you can't prescribe, You can't treat disease. It has to be generic health advice, but you can build up your client base and your practice and start to get your website out there and your name out there and so on while you're doing it. So that's something we help our clients on, and we have a sort of a graded insurance that starts at a fairly cost-effective level when you're just starting out and there's not so much risk, and goes all the way up to the fully fledged practices that do all sorts of fairly avant-garde treatments and use off-label medications in all sorts of ways.
It's really fascinating. And let's say we're then looking to the future. How do you ensure the longevity and overall health of your practice and your business?
Well, I think really dealing with complaints is, for any healthcare practice, that is the core of it. And that's something that's very much central to our business. We are not insurance people. We call ourselves insurance advisors because we're there to advise you all the way and not just pop up and give you this year's excuse as to why your premium's gone up by 10%. So our best clients we speak to very regularly. So it's about making sure you interface with patients' GPs to avoid criticism from GPs. It's making sure that you're very clear with patients about the treatment you're offering, why you're doing it, what the potential benefits are. One of the factors you have with functional medicine is it's designed to be more attuned to the body and a lot more gentle. So it's a lot less overt and apparent that anything's happening. So one complaint is it's all private, so it's like, oh, I've paid you all this money and nothing's happened. Especially with prevention. I mean, how do you demonstrate that? So that's the sort of trick to it, is very much, it's quite a PR exercise because you're always seen as a little bit out there. I mean, misunderstood is the word, that less so now, but when we first started, misunderstood was the word we always heard. And so when you're misunderstood, you
tragically
have to be
misunderstood, mostly.
So when you're misunderstood, you have to communicate and be understood.
Of course.
So anecdotally, from what I would say, there are two things. One, avoid picking patients up from family barbecues. Just don't do that. Just don't do it.
And that's from bitter experience.
That's very bitter. Yes, this comes from scar tissue, all of these things. And secondly, and you know, the FM guys in the audience will know, a diagnosis of exclusion is the least defensible diagnosis you can make. And that'll be the subject of a whole other video if we get that far. But avoid diagnoses of exclusion, and FM particularly lends itself to that.
Oh, well.
And avoid it.
Okay.
As well as family barbecues. Have a family barbecue, just don't take brochures
the work
along.
out of it.
Don't take business cards.
In fact, don't mention you're a doctor.
Don't mention you're a doctor, no.
Well, thank you so much, Chris and Roger. And thank you for watching too. I hope you found that really insightful. We are always here to support too. And make sure you look out for our next video.